on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury on the disc can cause annular tears to form. Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain.
Live. All right, good morning. I'm Dr. Deukmedjian, and we are here at the Surgery Center of Ara Deuk Spine Institute. Shot. And we're getting started on a surgery called the Deuk laser disc repair, spelled D-E-U-K. And this surgery is done to treat herniated discs, bulging discs, degenerated discs, and annular tears. Pretty much all the same thing, it's just different stages. All disc problems start with an annular tear, and then they progress to a bulge where the herniated nuclear material in the center, called the nucleus pulposus, pushes out through the tear at the back of the disc, causing a bulge, and then that can become a herniation if it gets larger. A bulge is a herniation. It's the same thing, honestly. And then it's just a herniation is a larger extrusion of nuclear material through the annular tear. There's no objective way to describe it, like certain sizes, herniation, less is bulge. Where are we at? Is that it right there? So we've placed our needle into the C4-5 disc, the first disc we're going to be treating. 2, 3, 4, 5. You can see this patient's had a fusion done, shot. All right, we just injected dye into the disc. We call that a discogram. One more shot. And then AP, you can see in the back of the disc there's a tear, and that's allowing the dye material to leak out the back of the disc into the area where the spinal cord and nerves are. Shot? Perfect. So show them the tears there, Jordan, on that picture, on the AP. There it is, Jordan, very good. And then show the other side. Yep. So you see the dye there is leaking out right around the nerve root in the foramen. And you can see the needle is in the center of the disc, which is where we want it to be. So the first step in the Deuk laser disc repair is to gain access through the anterior approach, through the front. This is not a surgery done through the back of the neck, it's done through the front, and it's called transdiscal. Lateral? All right, very good. Doc, you're still giving me some extension? You can relax at this point. I think we're good. Thank you. Our anesthesiologist had the patient in slight extension. We call it military. And shot, perfect. Now I got the guide wire into the C. Can you all tell what level that is? You can see the C2 bone, then 3, then 4, then 5. And right below this disc is a metal plate and screws. This patient had a fusion done on their neck, not by me, by another surgeon. And that fusion, I'm just going to inject a little bit of local before we make our skin incision. This has got some epinephrine and lidocaine and Marcaine. So the surgeon before did an anterior cervical discectomy and fusion, and that was done in New York, I believe, where this patient is from. And basically, the patient did okay for a little while, but then, as typically happens with anterior cervical fusions or any type of open surgery, the discs above and below start to break down and undergo a transformation where they become degenerated and painful. And so this patient has developed 2 herniated discs above the fusion that are annular tears with herniations that are causing horrible neck pain and headaches for him. And he's done everything he could possibly do, including a spinal cord stimulator, which you can actually see the lead of the spinal cord stimulator on that x-ray. That's what is in the spinal canal just behind his spinal cord. A very dangerous procedure, this spinal cord stimulator, and it didn't give him any benefit. He actually has turned off the spinal cord stimulator. Show our audience the spinal cord stimulator, Jordan, on the lateral x-ray, please. Yep. So you see the little black dots, those are the contact electrodes. They're made out of metal. And then what the spinal cord stimulator is connected to down below, you can't see it, but it's in his back, is a little generator or battery and a computer. And it basically sends electrical signals to those contact leads that you can see on the x-ray and creates a magnetic field that is supposed to interrupt pain signals in the back of the spinal cord from reaching the brain, which is just up there. But it's not working, and they don't work very well at all. The reason most doctors put spinal cord stimulators in is because they want the money. They get a lot of payment, they get a lot of money for spinal cord stimulators. Medicare pays around $30,000 for them, and for a pain management doctor who normally makes a few $100 for a procedure, that's like hitting the lottery. So I've seen all these pain management doctors recommending spinal cord stimulators for patients and putting them in and making big bucks. And that's really what's driving all this now venture capital investment into pain management practices across the United States. We get calls every week saying, hey, do you want to sell your pain management practice? We've got big money, we'll buy it from you, and then you just do all these spinal cord stimulators on your patients and we'll get the profits from it. So it's an absolute bastardization of healthcare and medicine. It's disgusting, it's shameful. There needs to be more regulation on spinal cord stimulators. Do we put them in at Deuk Spine? Absolutely we do, but we rarely put them in. And we only put them in patients who actually really need them, that have failed other treatments that are more appropriate, like the Deuk laser disc repair. Okay, we've got our guide wire in. I'm very happy with the positioning. We've lost 1 drop of blood. That's pretty standard for the surgery. I'm looking at my x-ray. The guide wire cannot move backwards to the spinal cord, otherwise it'll pith the spinal cord and paralyze the patient. So I have to make sure it doesn't move. All right, Diego, if you have any questions for me, let me know. I'm making a 4mm incision. It's literally the smallest incision made in spine surgery. It's 4mm. And the whole surgery will be done through a 4mm incision. Can you guys see this here, Diego?
Yes, we can.
So there's the incision. It's tiny. And I'm going to fix 2 discs with 1 4mm incision, most likely, as long as it's in God's plan. All right.
We do have a question.
Well, we have a question. Give me a minute as I do this. This is an important part. I don't want to lose focus. So here's your Raytech. So the Deuk laser disc repair is a revolutionary new surgery where, just a little bit, where we're actually doing what's called endoscopic surgery. Endoscopic surgery has been done for a long time in medicine. Shot? But it hasn't been done in the spine. It's been done in, the abdomen to take gallbladders out. It's been done to take even uteruses and things out. In gynecology, it's been done in general surgery now for years. It's even being done in ear, nose, and throat, like sinus surgery is done endoscopically. But it's never really been done in spine surgery until more recently. Shot? The problem is it's extremely good for the patient, but it doesn't pay the surgeon very much. So a lot of surgeons aren't doing it because A, they don't know about it, because they're being basically kept from knowing about it by the companies that sell, well, you guessed it, the screws and rods you're seeing down there. How much do you think those screws, rods, and cages make for the company that sells them? In this surgery that the patient had about $10,000 worth of screws and rods. Screws, cages, and plates. Okay? So the companies that make that $10,000, well, they control the education of surgeons. And if you don't believe me, go look at any surgery meeting, neurosurgery meeting or orthopedic surgery meeting. All the meetings have sponsors and advertisers, and that's the companies that make this metal. And basically they control the education of the surgeons, and they're not letting the surgeons learn about endoscopic surgery. I had to take it into my own hands, travel overseas. I went to learn from the South Koreans, a German surgeon and an American surgeon over in Phoenix, who's now retired. Shot. All right, that looks pretty good. We're right in front of the spine now, right on the anterior longitudinal ligament. Let's get a AP Coker. So I've moved the dilator, which is a skinny little metal tube with a tapered tip down along the guide wire, and I want it to be pretty much in the center of the spine, just above the plate. So we're going to get a quick view with an AP. AP stands for anterior posterior, and it looks perfect. And the staples, guys, those are in the back, right? Luis? Are that's these staples here?
Yeah.
Got it. All right. Yeah. All right. We had to staple the drapes so they don't migrate up and expose an unsterile area. Take that. All right. So now that I've verified that the dilator tip is in the center between the longus colli muscles, right against the anterior longitudinal ligament, it's an avascular area. There's no blood vessels there, so it's safe. I'm going to bring this thing down and advance it. Meanwhile, I'm going to keep looking and making sure that the guide wire doesn't move in, okay? Because I don't want the guide wire to push down and go further. Because sometimes you can actually pinch the guide wire inside the dilator with a little bit of tissue, and then you advance both, and you don't want that. So I'm advancing my dilator right now through the ALL and into the disc. Remember, this is an anterior approach. We're not going through the back. It's an incredibly sophisticated surgery that preserves the entire disc, so there's no need to do fusion or artificial disc afterwards. Shot? Making some progress. Now the herniation that we're going after, the annular tear and the herniation, is in the back of the disc, and that's where I'm headed for right now. Because the patient has worse right-sided symptoms and findings, I'm going on the left side. Shot? Of the spine. All right. So I'm going to take the guide wire out and advance it with a mallet. Shot. The mallet looks barbaric, but it's actually very safe. Shot. We're going to get to the other side of the disc. Shot. Right where the herniation is its worst. We're going to fix the entire disc herniation on both sides. So I'm very close to the back of the disc where the herniation is. I can actually feel the tear in the back of the disc called the annular tear with the tip of the dilator. So check it out. We got our dilator in. It's in perfect position. We've lost a drop of blood. We have a 4 millimeter incision. I'm going to bring my tubular retractor over the dilator and set it into its final position, where the tip of this tube is right against the herniation and the annular tear, and I'm going to use a laser to clean up the annular tear and remove all the fragments of herniation. And that's the whole surgery, folks. There's no metal. There's no $10,000 bill for screws and a cage and metal, which is why the companies that control spine surgeons in the United States and worldwide, companies like Medtronic, Alphatec, Nuvasive, Synthes, well, they're sold now, Deuk, Johnson & Johnson, okay, all these companies that sell metal for spine surgery, they're against this surgery because we're not going to be putting any metal in this patient. So they're keeping the surgeons from learning about this in the United States. It's a shame. That's why we do our own education and our own broadcasting, because ultimately we're in healthcare to help patients get better the best way they can. Shot. And that's to do what's right for the patient. And that's minimally invasive endoscopic surgery without metal and implants. Do I do fusion surgeries? Absolutely. I've done thousands of fusions. And I did fusions primarily because patients couldn't afford to do laser surgery and pay out of pocket. So they would just rely on what their insurance covered at the time. So for many years I did the second best surgery for them. And my results with fusions are very, very good. Better than 99% of surgeons out there. And so I was still helping people with fusion surgery, but once the endoscopic procedure became more readily available to people, that's what they want. So people travel now from all over the world to get this Deuk laser disc repair. You can see the dilator has moved backwards. We don't want that. So I've got to advance it again. And it just sometimes does that as you're hammering in the tubular retractor shot. Yeah, that's a little further than I want. Shot. 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 It can sometimes look bad on the lateral view because you're only getting a two-dimensional view, but I know three-dimensionally that it goes into the foramen and it's not that bad. Shot. But it's better just to be safe, and I'm just advancing this a few millimeters at a time. And using the mallet, I can actually gauge the amount of force that I'm applying to make sure it's the right amount of force. All right. Let me see. Again, you have to make a small adjustment with the dilator. Shot. Shot. And we're pretty close to our final docking position on the tubular retractor. Shot. Yeah, we're just about there. Shot. All right, that looks, let me give one more tap. That looks good. All right, perfect. So we're in position with our tube. So the whole surgery will be done through this little tube here. You see this here? A small little tube. It's a 4 millimeter diameter tube, and we're going to do the entire surgery through this 4 millimeter tube. That's why it's so minimally invasive. It's the true minimally invasive spine surgery. Everyone talks about how minimally invasive their spine surgery is, but this is the least invasive by far. There'll be no fusion, there'll be no metal, there's no need for artificial discs. All of that stuff is superfluous. As a matter of fact, this surgery you're watching right now will replace the 1 million cervical fusions and artificial discs done every year in the United States. Once surgeons learn how to do it, and once they're motivated properly to do it for their patients rather than, better paying fusions or artificial disc surgery. Basically, when the motivation becomes what's proper for a doctor, which is to do what's best for the patient, then everyone will be doing this surgery. Okay, so here we are at the bottom, and you can see this little area that the dilator created down there. Okay, where's my pedal? Yeah, I think so. Where is it? There it is. All right, we're at 20. So right now, what we're going to be doing is using this laser, which you can see the laser fiber, that little glass thing at 12 o'clock. It's generating or transferring laser energy or laser pulses to the back of the disc. And what it does is it basically vaporizes this abnormal tissue at the back of the disc. So, Diego, why don't you show our audience the video on why annular tear herniations cause neck pain, headaches due to the inflammation. Can you run that?
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
We're back.
All right, we're back. Hopefully you've been able to watch the YouTube video animation that Zach created with me, explaining how an annular tear causes so much pain. It's the inflammation within the annular tear, and that inflammation is created by the herniation, like this right here, getting stuck in the annular tear. And when the annular tear annulus comes in contact with the nucleus, the blood supply in the annulus comes in contact with the nucleus, what happens is you need that piece. You can't just throw it out. You have to save those. Okay? What happens is the nucleus pulposus causes inflammation. Okay? It's like bleach on your annulus. It's so, my laser guys, come on, got to get the laser back on. I shouldn't have to ask you. Pay attention, please. The nuclear material basically is so pro-inflammatory. It's like pouring bleach on your skin. It just causes severe pain and discomfort, redness, swelling, basically inflammation. Okay? So it's actually the nucleus pulposus, the jelly in the center of the disc, squeezing out through the annular tear, that is the cause of the inflammation. That's why you have to have a tear plus a herniation in order to get pain in the neck. And that's what this patient suffers from, is the neck pain and headaches that come from the inflammation getting on what's called the dura. Please don't touch the end. Why did you do that? That was clumsy. Come on, wipe. I hope you didn't break it. Yeah, I think it's fine. Yeah, just be cognizant of what you're doing, okay? All right, let's take the first question from our audience.
Our first question comes from Facebook, and our viewer is asking, for this patient, was an epidural injection appropriate? And would it be a temporary fix?
Yeah, so the viewer from Facebook is asking, for this patient, would an epidural steroid injection be appropriate, and would it fix the problem? So, great question. So breaking it down to simplicity, this patient has 2 herniated discs that we're going to fix today, and those herniated discs are basically, he has 3, but the third one we're not going to be able to reach, okay? But the herniated discs are basically the source of his neck pain, headaches, and it's these 2 that I'm working on right now, this one and the next one I'm going to do. Those are the majority of his headaches and neck pain, okay? Look at that herniation right there. So, since the source of all of this patient's symptoms is really inflammation, okay? Inflammation. Focal, we call it focal because it's in a focal location. It's not throughout the whole body. It's focal. It's kind of like a pimple on your face when it's really inflamed and red and tender and painful. That's really what we're dealing with, a very small little area in the back of the disc where there's massive inflammation. So is an epidural steroid injection appropriate? Absolutely. You can do an epidural, okay? And the problem with epidurals is that they don't work long term. They may give some temporary relief of symptoms, but then they stop working after a few days, a week, and then the patient's back again in pain, needing another treatment. So the Deuk laser disc repair that we're doing now is a one-time, one and done, you're fixed. As long as you don't re-injure the disc after surgery. Now, what's the chance of re-herniating your disc after the laser surgery? It's 1%. That means 1 out of 100 patients. I've been doing this 15 years. Every 100 patients we do, we get somebody who doesn't follow the rules properly or is just unlucky and follows the rules but just re-herniates doing, sleeping at night or doing something. They usually know what they did wrong, but sometimes they don't. This is the herniation, by the way, in the foramen on the right side at C4-5. And it's all scarred up. That's what I'm blasting away, literally layer by layer of the herniation. I'm peeling it away with the laser. Like peeling away layers of, this is mostly scar tissue from inflammation. But I can see there's still pieces of herniation in the foramen. And I want to make sure we get as much as we can so we treat this patient's symptoms. But we're all the way out in the foramen on his right side at C4-5. And this is scar tissue again. You can see I've excavated a lot of this herniation already with the laser. A lot of the fragments are already gone. Can make out the nerve root right there. A lot of times with these old herniations, the inflammation at the back of the disc and the annulus is so severe that it'll scar the what's called the posterior longitudinal ligament, which is like right there, and it'll scar it to the back of the disc or annulus. It'll just all scar together, and that's what we got here. And the yellow stuff, the gold stuff, is calcium deposits that are happening, and so I'm going to turn around and face the other direction. I'm going to head out towards his left foramen. So I'm turning my scope around, and we're going to start working the other way. And you can see the torn annulus there at 9 o'clock, those white fibers right there. That's the tear. That's the tear that allowed the herniation. And then you see the little white fibers there, right? Let's see if I can point them out. Right there. That's the posterior longitudinal ligament fibers. So you can see them going up and down. That's typical, okay? And all this stuff, this blue stuff, is the herniation. That's stained with our dye, our Deuk spine dye. That's blue color, right? Special dye. So this surgery is just repairing basically the annular tear and getting rid of the herniation that's pushing on the nerve and spinal cord. There's a piece of herniation there. Just a chunk. I'm trying to float it out without actually stopping my surgery, but it doesn't want to cooperate. Oh, here we go. Come on, almost out. There we go. Get out of there. Any more questions?
Yes, for the Deuk laser disc repair, do you need to stop eating and drinking before?
Yeah. So for the Deuk laser disc repair, do you need to stop eating and drinking beforehand? 100% yes. This surgery is being done with the patient asleep. This patient is not awake. Now, great question, because my colleagues that taught me the surgery, the beginning of the surgery, the very basics, they were the Koreans, the South Koreans, and they do this surgery with the patient awake. And so what I recognize right away is that with a patient awake, they're squirming around and moving, and it makes the surgery a lot more dangerous. And the reason for keeping the patient awake is just so the patient can say, oh yeah, my arm pain is gone. Well, guess what? I'm not treating just arm pain. I'm treating neck pain, headaches, and arm pain. So I don't need my patients to tell me their arm pain is gone, because 100% of my patients have had their arm pain gone after my surgery. And it's a lot safer with the patient completely asleep rather than having them awake. So the Koreans have had some paralyzed patients as a result of the patient moving during surgery, and then they zap the spinal cord or compress the spinal cord, and then they end up paralyzed, okay? They won't tell you that. They won't admit it, but I know, because I know people in the industry, and I know everything that goes on endoscopically for the most part. And I know they stopped doing cervical for a long time. Meanwhile, at Deuk Spine, we've gone beyond cervical. We now do thoracic herniations. We've been doing thoracic herniations for almost 2 years. We've done 11 patients. I was talking to a patient yesterday who may be our 12th patient, and he's got 2 thoracic herniations that the doctors have ignored for a couple of years now. The guy is walking around with a cane. He's in so much pain, and the doctors he's seen have just told him, you know, just do pain management. Well, there is no pain management for thoracic disc herniation, okay? It doesn't work. And these people need surgery to fix that thoracic herniation. So by these doctors denying patients treatment that will actually fix their problem permanently, they're not doing any good service to the patient. They're not helping the patients. You know, if you're not comfortable treating a thoracic disc herniation as a surgeon, fine. Send them to Deuk Spine Institute. We'll take care of it. We do it endoscopically. We do it minimally invasive. The other surgeons don't know how to do the surgery minimally invasive endoscopic. All they know how to do is, you know, what's called an open procedure, where they go in and they remove part of the rib and they move the heart and lungs over, and basically it's a major dangerous surgery, lateral extracavitary or transpedicular approach, which is what I learned how to do in residency in neurosurgery at UF in Gainesville. But the truth is that surgery is a very dangerous, very painful, like literally you're in the ICU for a week after surgery and you spend a couple of weeks in the hospital. It's crazy when I can do that outpatient in 30 minutes and my patients go home 30 minutes later and they're up walking and driving and shopping and working the next day. So there's serious advancement in spine surgery, and people are not aware of it because they're not being told by their doctors, they're not being told by their hospitals, they're not being told by their therapists, because those people don't know about these advanced treatments that are now available. Almost done with this one. You can see there's still herniation in the foramen laterally. I'm getting it out. You can see the little chunks just being released, flying away. And for those of you who have not watched this surgery before, you might be inclined to think that a herniation is just one big piece of disc material, but it's not. Most of the time it's little pieces that come out, a little bit at a time. That's what we have here. And the reason for that is actually quite simple. People think a herniation happens like, oh, I got a herniated disc last week. No, herniations happen in steps, like multiple steps. You understand what I'm saying? It's not a one and done. It's like you get a tear, and then the tear gets a herniation, and it's small, and then maybe the next time a little more comes out, and then a few weeks later a little more comes out, because once the tear happens, it doesn't heal. It's trying to heal. That's why you get the pain in the neck or back or thoracic. It's trying to heal, but it can't heal. And because it can't heal, that tear is still there, and every time you bend and pick something up, you're pushing more jelly out through the tear that didn't heal. And then it causes more inflammation and pain. Eventually it gets to your nerves and starts causing nerve pain. So, you know, understanding the disease is so simple now, and I've been trying to teach everyone about it, but so many doctors, like literally 95% of doctors, still don't understand it. So they need to watch our broadcast so they can learn something. But all of this neck and back pain is curable now. All of it. Just about done. Then we're going to move up to the next disc. Now, the reason I said we started with 3 discs to fix, but we're not going to get to do the bottom one because it is impossible. His anatomy will not allow it to be done safely, and I'm not going to put this patient's life at risk to do it. So if you look at his MRI, there's a very small herniation at C7-T1 below his fusion. But he's, I think we got that pain treated with the RFA, and Oh, look at that herniation coming out of the foramen. That was so cool. That is really amazing. Diego, time mark that. That was so cool. Big herniation just came straight out of the right foramen with a little bit of, you know, we had to release the scar tissue with the laser. There's another one. And the beauty of this system is that the laser not just vaporizes and burns things, but it also creates a pressure wave which blasts things. So there's a mechanical debridement along with the curettage that comes with the laser. It's like there's nothing like this in the world. Look at the foramen is opening and closing. This is on his right side. I don't see any more fragments coming out. I'm very happy with that. Once again, here's a fragment on the left side. I'll have to grab it because it's too big. So I use a combination of laser, 95% of the time is what I'm doing, and I also use a grabber called the pituitary rongeur that's made especially for endoscopic spine surgery. I get it from Germany. Did you ever locate those, by the way?
I bought 2 already.
Huh?
I bought 2.
Oh, dude, you're awesome, Luis. Thank you so much.
Thank you.
Yeah, you found Claris, right?
Yes, the same one.
Yeah, same one. Good.
So,
They still sell it, huh?
yes. Yeah.
Yeah. I would buy at least 2. They're expensive, aren't they? $1,200?
No, they're 800.
They went down in price.
Yeah.
Wow, that's good. All right, so I got a herniation here I got to deal with. I can see it's just scarred down. I'm going to have to turn my scope around and come back across. You could see all of this is herniation, scarred to the spine. All right.
We have a new question.
All right, I'll take the question.
All right, we have a Facebook viewer saying, what does it exactly mean when you say it's fused?
Fused?
Yes.
Oh, so we're not doing a fusion, obviously, here. I don't want to confuse anybody, but one of our viewers says, what does fusion mean? So that's a great question. You know you've got bones in your body, right? They're part of your skeleton. And some of those bones, like in the spine, we call them vertebrae. And careful now, you're manipulating my camera. You can't do that. Do you understand? By moving this, you're twisting my camera, you're twisting everything here. You can't touch that.
Don't worry about that. If you grab the cable, it has to be
Okay.
long.
So basically, fusion is when 2 bones grow together. 2 bones that are normally separated grow together. Or 2 bones that are separated grow together. So take your arm, okay, or your leg. Let's say you had a skiing accident and you crack your femur. Your bone just snaps in half, right? Well, the process of the orthopedic surgeon repairing your femur is fusion. It's getting those 2 ends of the broken bone to grow back together as a solid piece of bone. So basically, if you think about it on a microscopic level, what's happening is the 2 pieces of bone now, they used to be one, they used to be connected, right? They're cracked. And now the surgeon needs to get them to grow back together to make one bone again. So one leg bone, one femur, okay? So what the surgeon does is he, first of all, will make sure that they're touching each other the right way and that the alignment looks good. And then they will immobilize those ends so they don't move for about 3 months, 6 weeks to 3 months. And over those 6 weeks to 3 months, the bone surfaces will literally grow back together and fuse together. And that's fusion. Fusion is just the growth of 2 bones growing together to make one solid bone. And what's happening down there on the fusion surface is there's first inflammation, right, where you're getting inflammation. And then after inflammation, it usually goes away in 10 days to 2 weeks. Then your body starts to literally make new bone by cells called osteoblastic cells. And the osteoblasts lay down new bone, and osteoclasts break it down. And basically there's a remodeling of your bone at that fracture site or at the fusion site, which, by the way, to get a fusion done, the surgeon literally fractures your bones, surfaces, and causes those 2 bones, because of the fractured surface, this starts an inflammatory process that eventually results in the bones growing together, and we call that fusion, okay? So fusion is the growth of bones together. When surgeons do fusion in the operating room, we're not actually doing a fusion where we call it a fusion, but what we're really doing is just getting the bones fractured so that they will automatically, over time, grow together. Okay? That's what we're doing. So the fusion is what your body does. Surgeons can't really fuse your bones. Only you can. All right, we're done with this disc. It's clear and clean. Very happy. We're going to do the next disc next. So, great questions. Remember, we left the entire front of this disc alone. That's why we don't have to put a cage. We don't have to put an artificial disc, because the front of this disc is still there. We didn't remove it. Now, when you're having an ACDF, the surgeon has to remove the front of your disc. Okay? But we're not doing that, once again, because we're leaving the whole front of the disc there. And that's why we don't have to do a fusion. That's why we don't have to do an artificial disc. We don't need to put anything between those bones because we didn't take the bones out. I mean, we didn't take the disc out. All right. Alrighty then. So one disc down, one more to go. I'm not going to be able to do C7-T1. Again, I'm not concerned because that's because of his neck, his body habitus. He's got too short of a neck and too broad of shoulders. It's impossible to see. You can see right here in the x-ray, we can only see down to C5. We can't even see beyond that. So we need to get down to C7-T1. It's impossible. And there's no way to do this surgery safely without seeing the actual disc space with the x-ray machine. So that said, I think he's going to be very pleased with the results. I think his pain will be gone because most of his pain was high cervical at these two levels, and it was headaches, which usually comes from, you know, the upper cervical herniations. All right, let's get positioned gently, slowly, easy. All right, what other questions do you have for me? That's good right there. I'm going to move this because I think there's some contrast on it. All right, so what I got to do now is I've replaced the dilator shot. You can see it there. That's perfect. And I'm going to take this, my tube out, leave the dilator in. Shot. So I'm going to start taking the tube out. Remember, the tube has gone through all of that disc material. It's just a jelly, and it's pushed it aside and allowed me to have a tiny little path to the back of the disc where the tear is, that I could repair it, and where the actual herniation is. And look at this. This is bloodless surgery, you know, truly bloodless surgery. Shot? Okay. So my dilator is still in place. I'm going to apply pressure for just a minute while I regain composure here, get everything set, my fluoro set. It looks good. I need to get my anesthesiologist to hold the neck in inline traction with slight extension. So while we're getting ready to get to the next disc, I'm just going to apply a little bit of pressure in case we have any venous bleeding, which I don't think we do. All right, so you're extended. Let me take a look at what we got. Looks good. All right, so I've got to bring my dilator out under fluoroscopic guidance, out of the disc, and sit it on the front of the spine. Shot. This is the hardest part of the entire surgery by far. Shot. And it's all feeling. And I can tell you right now, 95% of surgeons cannot do this. Shot. But I can, as a neurosurgeon. All right, let's get an whoops, one more time, shot. I think I went back in. I'm going to come back out, right there. AP view, quickly. So I want to see where I am, shot. Yeah, so I'm a little bit off to my side. I want to come back, shot. Perfect, now go back to a lateral. So I'm going to use two views, AP and lateral fluoroscopic views, to navigate from the first disc to the second disc. Okay, so shot, shot. I need another AP, see where I am. So Jordan is moving the machine back and forth. Yeah, I can't take my hand off. It's got a big bone spur anteriorly. So I'm a little bit off to his side, which is fine. I'll bring it back. Shot. How are you doing, doctor? Shot. Perfect lateral. Could be a little bit more to the other side now. You see how I move the dilator under fluoroscopic guidance? Gosh, that's beautiful. That's beautiful. Everybody hold still. We're almost done. AP quickly. So I'm happy with my lateral view. I'm sitting right over the 3-4 disc in the front, in the center. I think I'm in the center. Yep, that shows me that I am. Let's go back to a lateral view. Of course, I'll verify this one more time. I need the mallet. Mallet now. I'm going to tap in to the ALL shot. Shot. All right, give me an AP, Coker. So I'm using my side view and my front view, going back and forth to check the position of my tip of my dilator. Shot. Yeah, that's really nice, actually. Yeah, that's really nice. Lateral. Mallet. Almost done. All right, that looks really good. Something is, all right, that looks good, yeah. Shot. All right, that looks good. Shot. All right, take this. Now we're going to clean the pipe because some tissue got in the middle of there through the front of the dilator. So you're watching the most advanced spine surgery in the world. Again, you're not going to see it anywhere else because other surgeons don't know how to do this around the world. But this is surgery done without implants, without metal, without biologics, without cadaver bone, without fusion, without artificial disc. And that's why, because we're not using these big companies' implants and making them rich, that's why you're not hearing about it, because surgeons are doing the surgeries that make themselves the money and make the companies the money. I need the mallet, guys. Come on. This has got to go all the way into the back. Come on, you guys know, you know that. Shot. 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 If I had a need for spine surgery, I would want to know what my options were. I would want to know the truth. And you're not going to get it from your surgeon, unfortunately, because they don't do the surgery. So how are they going to make money by sending you somewhere that does the surgery? They're not. We don't pay for referrals. Nobody does. It's illegal. So the only way you're going to get the information about this surgery is if you find out yourself from us teaching you, because your surgeon isn't going to say, oh, the best surgery for you is endoscopic laser surgery, but I don't do it. Mallet, come on. Do you see the tip has moved back? What do you think I'm going to need next? Sean? Yeah, I know that you're new at this. You're training, but at the same time, you've got to be using your brain. Okay? Nope, leave that alone. Shot. So again, I'm gonna bring my shot. I'm gonna bring my tubular retractor down. How are we doing? What are you still doing some with the neck?
Yes.
Can you flex it, extend it just a little bit? Sorry, extend.
A little bit more?
Yeah, a little more. We're almost done. I'm just about to the front of the spine shot. And just a little more extension. Are you extending him? Yeah, that's nice. So I want to get my tube to the front. I could actually start to feel it right now. Good. All right, my dilator is moving back again, but I'm not terribly concerned just yet because I still have a little ways to go with my tube. Shot. Shot. Going through the ALL. Shot. Yeah, now we're advancing. Shot. Beautiful. So you can see the back of the vertebral body and the tip of the dilator is kind of lined up right there. That's where the annular tear is. Look right in front of the dilator, just to the left of it. There's a tear in the back of the disc. That's the annular tear. So we literally dock right at the annular tear, right where the herniation begins. That's the beauty of this surgery, is we're not damaging anything in this patient's body except we made a cut in their skin that's 4 millimeters, which is nothing. I mean, gosh, a shaving cut on your skin is worse than that sometimes. And the rest of the stuff below the skin, we're not damaging at all. We're just spreading it. It's called spreading it. And spreading tissues in surgery is always very safe. And it's the preferred way to get down to your surgical site. It's the preferred way, shot, to do your exposure is through spreading tissues. Just take that off. Shot. So once again, I'm almost there with the end. Nope. Shot. Almost to the back of the disc on my lateral view. Shot. Almost there. Shot. Just about there. Perfect. That's it. Maybe a little bit more. I'm right at the beginning of the tear. I want to get into the tear. Shot. Just have to be careful. You want your dilator to always be there guiding you because it prevents you from doing what's called a biopsy. You don't want a biopsy necessarily. It's not that helpful to get a biopsy. All right, perfect. So we're at the back of the 3-4 disc. And again, for those of you who joined us late, you can see a spinal cord stimulator in the back of the spinal cord there. It goes all the way up to the bottom of C2. Completely useless, except it did make his surgeon that put it in a lot of money. Sure, if he looked at his what's called the EOB, explanation of benefits, you'll see how much his insurance actually paid for that thing. It was probably close to $30,000. So useless, $30,000 expense. Honestly, if the insurance companies all got rid of fusion for the most part and just recommended or promoted endoscopic surgery and appropriate treatments like not spinal cord stimulators when they're not necessary, then literally we would save billions and billions of dollars in expenses by doing these surgeries we're doing right now, the endoscopic surgery, because it's much cheaper than a fusion surgery and it's much better than a fusion surgery. And we don't have any hospital stay. For those of you who don't know, this surgery is being done outpatient. Right here at Deuk Spine Institute, outpatient. In the Surgery Center of Viera. It's our partner surgery center here in Melbourne, Florida. The Space Coast. This is where the rockets go up, folks. This is where Mickey Mouse vacations on the beach. He comes to the east coast of Florida from Orlando with Minnie and the entire family of Disney. You don't believe me? Take a look at the Disney buses that are always on the 528. And it's got the entire Mickey Disney crew on the bus. I could see it every time I drive by those buses. You can see their silhouettes. Huh? Has everyone seen them? Yeah?
Oh, yeah.
All right. Well, it's also true that Disney has a cruise line, and they work out of Port Canaveral, Cape Canaveral, Port Canaveral, which is right here where we are. So we're right near the Disney cruise line. Any questions from our audience?
Yes, we have another comment from Facebook. It says, is there any way to fix a tear?
Is there any way to fix what?
A tear.
What kind of tear?
In the annulus.
I'm sorry?
In the annulus.
An annular tear.
Yeah.
Yeah, that's what we're doing right now.
Uh-huh.
We are fixing the annular tear. This surgery you're watching is the only way to fix the annular tear. There is no other way. The surgery you're watching right now is the only surgery in the world that fixes the annular tear currently in the year 2021, right when we're doing the surgery. Now, will there be copycats of my surgery and technique? Of course there will. Once everyone figures out, you know, what I'm doing and how to do it, there will be people copying, and that's fine. But in the end, Deuk Spine Institute and Dr. Deukmedjian were the first in the world to annular tear repair. And I published it in 2012. That's almost 10 years ago. That was our first publication in a peer-reviewed journal, Surgical Neurology International. So we're the first to publish it 10 years ago. I've been doing the annular tear repair for 15 years now. Started in, I want to say 2006 was my first surgery I did. So, yeah, this is it. This is how you repair an annular tear. Why don't you run the animation, Diego, of how the Deuk laser disc repair works, how it repairs the annular tear.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI.
All right, so welcome back. We just had a really good question from one of our audience saying, you know, is there a way to repair the annular tear? So we decided to run our animation video that we created to explain how annular tears are repaired in the neck, in the cervical spine, with the Deuk laser disc repair procedure that we're doing right now. And hopefully it makes sense. Long story short, the annulus fibrosus, that's the tear right there in front of the laser, by the way. The annulus fibrosus is a membrane that holds the jelly into the center of the disc. And so when you get a tear in that membrane, the jelly can leak out through the tear, and it can cause all this pain and inflammation for the patient, terrible pain through inflammation. So what I do is I go in endoscopically, and I can use the laser to clean the tear. We call it a debridement. All right, so I'm trying to make it simple to understand, but we call it a cleaning. So the tear is trying to heal, but it cannot heal. It cannot heal because the herniation is stuck inside it. And as long as that herniation is stuck in the tear will not heal. It'll keep trying to heal, but it won't heal. And as long as the tear is not healed, more herniation can come out. And there will be more pain, more inflammation, more herniation. So what I'm doing is I'm removing the herniation stuck inside the annular tear, and I'm debriding the tear itself. Because by now, with all that inflammation, what's happened is the herniation fragments are now stuck to the annular tear. So we literally have to do what's called a debridement, where I have to clean out the tear and the herniation fragments in order to get the tear to heal properly. When the tear is healed properly, the disc is rejuvenated. Basically, it's repaired. But the disc cannot heal itself and repair itself as long as the tear is there with the herniated disc material in the tear. That's all this junk right here we're trying to get out. Lots and lots of pieces. Now look how different this disc is than the last one. This is a newer herniation. I can tell because it looks more like fluffy little clouds, and it acts differently. If you notice, it's not as scarred down like the last one was. So there's a piece of herniation there that went out through the tear and is sitting on the spinal cord, and I'm breaking it down a little bit at a time. It will probably release any second now and just pop out. It wants to come out. You see that? It's like trying to get its head out. This fiber just keeps pushing backwards. What is our next case anyway? That's a 5-level lumbar? Okay, thanks. So if you settled in for watching our surgeries today, we actually have the next surgery is going to be lumbar for lower back pain and pinched nerves, sciatica. Our patient is also from out of state and did not want to have fusion surgery on his back, so he's here for the laser surgery on his back. I'm going to flip my scope around. There's a lot of this herniation back here and a lot of disruption of the annular tear. Wow, just a lot of pieces of herniation. Probably 8 more minutes.
We have a new question from Facebook.
Sure.
Could cryoablation be used on scar tissue in the spine to stop pain?
Just a little more louder. I just really couldn't hear it.
Okay.
I just heard cryoablation.
Yes, could cryoablation be used on scar tissue to stop the pain?
No, cryoablation doesn't really work. It doesn't stop the pain. And again, it's not scar tissue that causes the pain. It's inflammation inside the annular tear that causes the pain. Okay, that's very important to understand. Oh, look at that giant herniation. So it's the neck and back pain that comes from a herniated disc or thoracic herniation. It comes from, oh, that's huge. It comes from the little nerve fibers that are normally found in the annulus fibrosus, on the periphery of the annulus fibrosus, the outer part, the outer half of the annulus fibrosus. It has pain fibers there. So scar tissue itself doesn't have pain fibers, but the annulus fibrosus does. And so the back pain, neck pain doesn't come from scar tissue. It comes from the annulus fibrosis. So cryotherapy doesn't work unless they're doing something funny in there, which I don't know. Wouldn't surprise me. But we don't do cryotherapy at Deuk Spine because it doesn't work. It's just unnecessary. I mean, we'd do it if it worked, but yeah. Cryotherapy itself doesn't work. So Are they doing something else when they're in there that's making improvement in pain? You know, there's other things they can do. And I don't put any kind of dishonest behavior past doctors these days. There's a lot of charlatans out there. All right, good question though. It's a fair question. Wow, this is a very different herniation, huh, compared to the last one. Just so much soft, fluffy material, herniated disc material, so much compared to the last one. The last one had a lot less. It was an older herniation, more scarred down, a lot less of the fluffy stuff. The fluffy stuff over time gets worked on by inflammation and gets compressed and scarred down. This is taking quite a bit longer than I expected it to, but that's fine. We stay and do whatever's necessary to do. You know, there's no time limit on my services for patients. You stay till the job is done. Great questions. Any more? We're just about done here.
Will the patient need any medications or antibiotics for this pain?
Will the patient need pain meds or antibiotics for the pain?
Mm-hmm.
The answer is no. When you do this laser surgery here at Deuk Spine, there's only Tylenol and anti-inflammatory medicine, and we give a muscle relaxer just in case the patient's having muscle spasms after surgery. Some patients do. But we don't give any narcotics or opioids because there's not that much pain. You could see the surgery is done with a small incision, and the patients generally don't have a lot of pain after surgery. We're not creating pain because the incision is so small. Most of the pain meds patients get after spine surgery is because of the damage the surgeon does during the surgery to their muscles and tissues. Think about that. The pain people get after spine surgery is not from the screws and rods going in. It's actually from damage to the muscles of the spine. That's why people have so much trouble. This is a great surgery if you're a singer, because we're not going to be affecting your voice with the surgery. We're not manipulating your vocal cords that much. Sure, the tube goes in past the vocal cords because they're intubated, but that's a standard general endotracheal intubation. But it's not like we're doing an ACDF where there's a risk of injuring the recurrent laryngeal nerve and having permanent vocal cord damage or immobilization. Hey, Doc. Quick question for you. After the surgery, would you mind taking a look at that patient we talked about?
Absolutely.
She's in pre-op.
Okay, they brought me her chart.
Yeah, and her CT scan results are there. The, what's it called? The pulmonologist absolutely screwed her over. Told her to come this morning at 9. And then when she got there, they said, oh, we don't take your insurance. And I said, I'll pay for her to be evaluated myself. But by then the guy said, oh, I'm in the hospital, I can't go see her. I said, she drove 3 hours for you to do a clearance, and how could you do that to her? You told me yesterday you'd be happy to see her and evaluate her. And he basically lied to me. I was so disgusted. So she went all the way up there and they turned her away. Sure. Yeah, we can talk about it. You're concerned about the recovery or what?
Actually, I think it would just be helpful information to have some TFTs on her,
Oh, okay.
pulmonary function test, because she also
Uh-huh.
looks like she's had some residuals from a possible pneumonia and
Sure.
some interlobular emphysema.
Sure, sure, sure.
So,
All right, whatever you want to order, just order it,
okay.
and we'll find someone to do it.
All right, super. Thank you.
Are PFTs something that are anesthesiologists trained to do that?
No, we are not.
You're not. So you have to be what?
Pulmonologist.
You can't have a cardiologist do it?
Cardiologist can do it, sure. They can
Now,
do
she
it.
has a clearance from her pulmonologist coming.
Oh, she does? Okay.
Yeah. It's actually being faxed today.
All right, well, we'll take a look at it all.
So just take a look at that and decide what you want to do.
Great, thank you.
Just about done. Oh, this is such a pain in the butt. Won't come out. Grab her. I say 5 minutes. There was a much bigger herniation here than the last one. This is a newer herniation too. I think, and this is higher up. This is probably what's causing his headaches, if you ask me. So, but you can see big tear, big herniation. So the surgery is quite an interesting. It's like a PCDF, but I just exposed the upper half of the spine down to C4, and I just fused C1 and C2. It's a C1 C2 fusion for C1 C2 instability. I've done now 5 of them in my career because it's not a common problem, and all 5 patients have had 100% relief. I mean, their pain's gone away 100% and never come back. You know, it's pretty cool. We're talking about our surgery for next week. A patient with C1, C2 joint disease and what we call instability. And she's having a C1, C2 fusion done. And that will be one of the, I've broadcast them before. Come on. I've broadcast them before. And we have them on our archive. I've done several of them here at the surgery center, Deuk Spine. So they're probably there. You should look for that, Diego, and maybe we do just a quick like, hey, this is what we're doing next week, you know? It'd be kind of cool. Boy, this herniation just goes on and on. This is the one causing the headaches, though. It's going way past midline. You know, this is all herniated disc right here. It's just little pieces coming out. There aren't many neurosurgeons that do endoscopic surgery. And endoscopic surgery is now being done in pediatric neurosurgery for treatment of hydrocephalus. So there are some pediatric neurosurgeons doing endoscopic surgery of the brain. And I was at a meeting in Florida for the Florida Neurosurgery Society just a month ago, and I got to watch some of the latest advances in endoscopic surgery for kids with hydrocephalus and tumors. And some of the pediatric neurosurgeons are just starting to do endoscopic surgery. I was kind of appreciating it because it's really nice for the kids not to have shunts put in, and which, you know, malfunction quite often. Then they have to come back and have a shunt revision done.
We have a new question from Facebook.
Sure.
What is the difference between a discectomy and a laser? And is the laser more effective?
Yeah, so a discectomy means you're taking out a disc herniation. So it's just the pieces of herniation, and they're grabbed and pulled out. And you're asking the difference between a discectomy and a Deuk laser disc repair?
Yes, and is the laser more effective?
Yeah, so the Deuk laser disc repair surgery that I'm doing is more than a discectomy. It's a discectomy, but it's really the annular debridement, which is what I'm doing right now. That's not part of a discectomy. The surgeons that do discectomies don't do this debridement. They're not cleaning the annulus out with the laser. So yes, the laser is the only way to do a debridement of the annulus and the annular tear. That's the only way to do it. And is it more effective? 100% more effective. Discectomy doesn't cure neck pain. Discectomy doesn't cure headaches. Discectomy only treats arm symptoms like numbness, tingling, weakness. So yeah, the laser surgery is far more effective. It's the only way besides fusion to treat neck pain and headaches from herniated disc, because it's not the herniation that itself that causes the neck pain and the headaches. I got 5 minutes really now. That was one of the biggest herniations. The whole back of the disc was just destroyed. But now I'm seeing light at the end of the tunnel here. So if you go to a spine surgeon and say, I have neck pain, will you do a discectomy for me? They're going to say no. Discectomy is not done to treat neck pain. Okay? Discectomy is done to treat arm symptoms or spinal cord compression. And that's because discectomy is only done to treat arm symptoms. In the neck, of course, or leg symptoms in the back. But we're not interested in just treating this patient's arm symptoms, because they also have horrible headaches and they have neck pain, and they want that neck pain and headaches gone. So if I just did a discectomy, his neck pain and headaches would still be there. But he doesn't want his neck pain and headaches to still be there. He wants them to go away. So you have to do the annular debridement with the laser to treat the neck pain and headaches. All right, we're done.
Lights on, please.
Take that. Turn off the scope.
Suction off, please.
Yep.
Thank you. Yep. Thanks. All right, you can
We're just using a little, what we're doing is we're using a little antimicrobial antiseptic, basically. The same kind of betadine you'd put on, like if you had a boo-boo. It's developed by NASA, really to kill any kind of germs that the astronauts might have encountered out in space. Make sure that nothing was brought back, You know, like you see in those science fiction movies when they bring some alien life form back that takes over and kills everyone. So, all right, I'm going to show you our incision, which is 4 millimeter. Take that. Take that. Give me a second and I'm going to show it to you, okay? I just got to apply pressure. All right, any more questions from our audience?
Just someone saying thank you for your response.
Yeah, you're welcome. Again, I'm Dr. Deukmedjian. We're at Deuk Spine Institute. If you haven't downloaded our app, we have the Deuk Spine Institute app. It's free. Go to your app store and type in Deuk, D-E-U-K, Spine Institute. It's a great app and highly recommend it. Also, check out our YouTube channel and our TikTok and Instagram, Facebook. We have a Facebook support group called the Spine Surgery Support Group. It's really cool. All right, there's the incision, folks, right there, 4 millimeters. You see it? Look at that. Incredible, huh? We're going to do a Band-Aid and we're done. Nice work, everybody. Let's see if they've got bigger radiation gloves for me other than those 9. See if you can return them. I don't have a problem with the gloves per se. I do like these better because they're thinner.
Yes, sir.
But the other ones are too tight. All right, type up your questions for me. I'll be there
Disc
to answer them for you
herniations are
shortly.
a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Wendy's.
Nope, you've got Moe's.
Oh.
you. Let's go. Let me take off studio. Take off this. And take off that. You are live.
Well, hello, it's the new and improved Dr. Deukmedjian here for you. We just wrapped up an anterior Deuk laser disc repair. And if you followed us for the surgery, you noticed that this patient actually had a metal plate already in their neck. So I didn't put the metal plate there. They didn't know about the Deuk laser disc repair when they had that surgery done. They're actually from New York. They traveled down here to have the laser surgery done. Basically, this patient had 2 bad discs before. They were treated with a decompression infusion. And as a result of that surgery, he had a metal plate left in his neck like everybody else does with an ACDF. He developed degeneration of the discs above the fusion, 2 of them. And I went in above the fusion and I repaired those 2 discs today. We did that endoscopically. There's no need for metal. There's no need for plates and screws. It was all done naturally by repairing the back of the disc where there's a tear and a herniation and multiple fragments. I got them zapped with the laser, got them all out. You watched them coming out throughout the surgery. And now he's got a nice clean area in the back of the disc. That's going to heal beautifully in the next couple of months. It really takes a year to fully heal a disc after the Deuk laser disc repair, and that's nothing to do with the surgery. It has to do with the fact that discs are not well vascularized. They don't have much blood supply. What tissue in your body has the most blood supply per gram of tissue? Anybody know? Well, I'll give you a hint. I know because I'm a brain surgeon. It's the brain. The brain has more blood per gram of tissue circulating than any other place in your body. The second most is your kidneys and then your heart tissue. So really the brain, the heart, the kidneys have the most blood supply going. Now, what tissues have the least blood supply? Well, the lens of your eye has 0 blood supply. It gets everything through diffusion. And of course the disc itself has very little blood supply. So that's why it takes so long for the disc to heal after surgery like this. Even if the surgery is done perfectly, the disc still takes a long time to heal. All right, we had some good questions throughout the surgery. One question was, how do you repair an annular tear? Well, that's the Deuk laser disc repair, what we just did. That's the only way in the world to repair an annular tear. You can see behind me, we're just finishing up that surgery, and we did not get to the C7-T1, so it really is a 2-level Deuk laser disc repair because the C7-T1 disc is too far down, and the patient clavicle right here is blocking access. His big shoulders were blocking my ability to see that C7-T1. Good news, the C7-T1 disc is the least of the disc problem, and we were hoping we'd be able to get it, but I had a suspicion we may not. We were able to do the rhizotomy back there before. I did my part with Dr. Patel, did the rhizotomy, and that went smooth. I think our patient's going to have 99% relief of his neck pain, headaches, and arm symptoms as a result of our surgery today. The Deuk laser disc repair is the only surgery in the world where you get about 98-99% relief of neck pain, headaches from the neck, and arm symptoms. Those are our most recent numbers. When we originally published our research, we were getting around 90-92% relief, but it's gotten better over the years. All right, any questions from our audience?
Okay, yes, we have a question. Will the patient have any drains or other tubes when leaving the facility?
So great question. Will this patient or any patient with the Deuk laser disc repair have drains or tubes when they leave this facility? The answer is no. There's no need to put any drains in the neck with the laser surgery because you saw the incision. It's literally 4 millimeters. It's tiny. And the path that I created from the skin down was using almost like a pencil, a metal pencil. And this is honestly far bigger than that. But if you look here at the tip, that little metal pencil, we call it a dilator. That's the term used in endoscopic surgery. The dilator went down the guide wire, and it literally, that little tip, because it's tapered, right, tapered down, as it gets through the tissues, it literally spreads them apart. It doesn't cut them, so there's no bleeding. It doesn't rip the blood vessels. So all these surgeries are bloodless. There's no need to put a drain. The only reason you put a drain is when you get a lot of internal bleeding from surgery. Now, when I do my ACDF surgeries, I never put a drain either because I know how to do the ACDFs without bleeding as well. But a lot of surgeons they make a dog's breakfast out of this, and it's all bleeding and oozing, and they got to put a drain in. Honestly, it's just sheer incompetence. I would never go to a surgeon that uses a drain on your neck. It just means they don't know what the hell they're doing. Next question.
No, that'll be all.
All right, looks like I have a dinner date tonight with my wife, celebrating our anniversary, which we missed. It was actually 2 days ago.
Congratulations.
Thank you. All right, I hope to see some of you for our next surgery. Remember, Deuk Spine Institute has got the app, and the app is free. You can download it. It's got a lot of good information, and Zach's working on a revision. Also, besides the app, we've got our Facebook support group called Spine Surgery Support Group. You can go there, and you can ask any question you want related to the spine, and we'll get it answered for you. We give you honest answers. I don't mess around with technology that doesn't work. I don't feed people a line or BS. We're going to give you a straight up honest answers, okay? And we got some more spine scams exposed YouTube videos coming up, right, Diego, that we're going to be working on this week. Honestly, there's no end to these spine scams, and so I can envision this segment of our YouTube channel going on for a long time, and we'll talk about all these important topics and all these scammers out there that pretend to treat neck and back pain that really don't. All right. Also, don't forget about our free MRI review. If you've got someone that you know that's suffering with neck pain, back pain, thoracic pain, we can help them. As a matter of fact, we do a free MRI review. You upload the MRI or send it in, and I look at it, and I'll do a video conference with you for 10 to 15 minutes. We'll show you what's wrong. We'll tell you exactly what needs to be done to fix it. And more importantly, if you've got another way you want to get it fixed, that's fine. We'll talk about the pros and cons. So it's a really educational, informative session for anyone that's got a herniated disc, bulging disc, spinal stenosis, degenerated disc, whatever to do with the spine. Happy to take those MRIs, review them, and do our video conference. All that's free right now. We don't charge for it. So just get signed up with Maya and fill out the free MRI review link. Have a great day. It's been enjoyable